Okay, so we're gonna move to the next talk, and it's my pleasure to invite Lisa State to talk about 18-fluorodopa PET scan in the diagnosis of focal hyperinsulinism. And I think we will give you time at the end to ask some questions, because I know many of you in the audience may still have the question of whether your child will benefit from 18-fluorodopa PET scan.
Hi, you won't see my name in the program. I had a commitment, but I was able to rearrange my schedule to be here. And these are Susan's slides, and I am the wizard behind the curtain. All of you, or most of you, probably know Susan. I am a radiologist, and I specialize in pediatric body imaging and in pediatric nuclear medicine. So I'm the one who tells Dr. Adzik, here's a lesion, here's where you go, but you probably haven't seen me if you've been in the hospital. So what is a PET scan? PET CT scan. It's a marriage of physiology and anatomy. So you can't do both with a PET scan alone. So the CT scan really helps us use it as a roadmap. So I can say to Dr. Adzik, go right here. So what the PET scan does is it picks up abnormal physiologic activity that would be missed by other imaging studies, such as MRI, CT, X-ray, or ultrasound. And it is a radioactive material that is tagged to a naturally occurring substance that your body uses. F-DOPA is used to make dopamine by the body. Okay, so the fluorine-18 is an unstable radioactive material, and what we do is we can actually, as it decays to find its stability, we can measure the radiation with the detectors on the PET scan and create an image. So the patient, your child, would be injected with the radiotracer. The radiotracer would travel to the areas in the body that are going to pick it up, and the pancreas happens to be one of those areas. Also the liver, the kidneys, and the brain. And since we're interested in the pancreas, we just image over the pancreas, and you'll see some pictures shortly. So again, the radiation comes out of the body and hits the detectors. And we can use these special computer algorithms to figure out exactly where that radiation came from. So here's a picture of a PET CT scan. So it's actually a PET scan, PET scan next to a CT scan. And these two parts of the scan are actually separate. And we can move them apart. Let's say we slide the baby into the middle. We can see down the bore, which is the hole in the machine, so we can see if anything's going on. And we have an anesthesiologist there, so we're monitoring everything, the blood pressure, the heart rate, the respiratory rate. But if there's a problem, we can run in, separate the scans, and get to the baby. So it's really an interesting design, but it's a very, very safe machine. So as Diva discussed, we are interested in your babies that are diazoxide unresponsive, okay? And this is where our role starts. And basically, the baby will be tested to see if they are diazoxide responsive. Once they are determined to not be responsive, they're taken off the diazoxide. They may be put on glucagon, and we have been able to leave the babies on glucagon for the PET scan, and we haven't seen any interference. So they come to F-DOPA PET scan, and we try to find these focal lesions. So the PET scan is not 100% accurate. So in about 85% of the time, when there is a focal lesion present, I can find it. But there are 15% of patients that have a focal lesion that I can't find it on the PET scan. So that's why we don't use this as a screen for focal disease. So some people come in and they say, well, they didn't find the focal lesion on the PET scan, I don't want to have the surgery. Well, your child may still have a focal lesion there. Okay, so it's really for finding that lesion, finding exactly where it is. So it's a shorter surgery. Dr. Adzik knows where to start. And that is the real key role in using this PET scan. So what are the benefits from having a PET scan? So first of all, you have to know that you are going to have your child undergo surgery. Okay, we don't enroll, we try not to enroll patients that aren't going to have surgery. But you must be planning to have surgery. We have all of our children genetically tested prior to the PET scan to make sure they have this potassium channel defect with an abnormal gene from dad. Now, we will scan patients where no genetic defects are found, and some of those patients still have focal disease. So we understand they may have the genetic defect only in the pancreatic lesion, but not in the blood. So we do scan patients that have no known genetic mutation. But the patients that have diffuse disease by genetics, we do not enroll in the study. And in this country, F-DOPA is not FDA approved. So in Europe it is, and in Brazil it is, but it is not yet FDA approved. So we have to follow strict guidelines. We operate our research study under an investigational drug license. And we report to the FDA every year. Okay, we follow our patients very closely. And some of you may have had PET scans where your baby is awakened by the nurse at 2 in the morning to get their vital signs checked. Well, the FDA wants to know if this is a safe study and to know if the F-DOPA is affecting their vital signs. And it is very important for us to collect this data. And the other reason it's important for us to collect this data is we have to show them that it's safe if we want to get this drug approved. Right, so we need this data, so we do need your cooperation. I know it's difficult being in the hospital and the babies aren't sleeping because it's noisy and they're interrupted, but we need your cooperation in order to help us push this further and really make this something that is going to be approved. Okay, so we don't do PET scans on everyone. I think I went over this a little bit. The sensitivity is 85%. The very small lesions, less than a centimeter, can be missed on the PET scan. And again, if your child has a mutation consistent with diffuse disease, they are not eligible. Okay, and this is just Dr. Adzikart. Oh, you didn't show the video. Well, this is not a video either, but there's a video on our website that shows the tracer coming through the bloodstream and the hot area, the focal disease area lighting up. But I'll move. Actually, I don't think. I'll move on. So this is an example of a PET scan. So again, we do 2 CAT scans as part of this study. One is to correct for the soft tissues on the PET scan, and it doesn't use any IV contrast. Then we use an IV contrast study so we can see where the vessels are and give Dr. Adzik a better idea of where it is. So this is a focal lesion in the head of the pancreas. This is a 3D image of the PET scan. It's just a single shot of that. And you can see that the head has increased activity. But you can also see, again, the liver takes up the radiotracer and so do the kidneys. And this is an example of diffuse disease where there's a similar intensity throughout the pancreas. So this is diffuse disease. Okay, now here are a variety of cases with focal disease. This is a focal lesion in the pancreatic tail. And that is a lesion that may be amenable to laparoscopic surgery instead of open surgery, but that's a decision that Dr. Adzik makes. And this is a lesion in the head, and this is deep in the head, and this might be something that might not be easy to see on surgery, right, or feel. Dr. Adzik is very good at seeing and feeling these things, but there are some areas of the pancreas that can be very difficult. And this is an area, again, in the tail, and you can see there, sometimes the kidneys can obscure lesions in the tail, so we take extra special care to look in these areas. So Again, we call it the GPS for the surgeon, for surgical planning. We direct the surgeon to the exact location of the lesion, and it can hopefully limit the amount of pancreas removed and prevent future diabetes. And the location, again, may be ideal for a laparoscopic procedure and maybe a shorter recovery. Now, we've had a couple odd cases. This patient had a few surgeries at an outside hospital and was still hypoglycemic. They came here and had a PET scan, and we found this is an unusual case. There's uptake in the residual pancreatic head. I think the rest of the pancreas was already removed. And then there were these 3 dots that changed position on the scan, and they were found to be in the jejunum, the small intestine, and sometimes the pancreatic tissue can migrate into other parts of the bowel. And these happen to be areas of focal disease in the bowel. This is really unusual, and we can't really I can't explain how that happened. And this is a patient with Beckwith-Wiedemann syndrome, has big kidneys and a big pancreas. And we went back and reviewed our experience with the Beckwith children and found 3 out of 15 babies had a focal lesion. So this is just another part of the spectrum of HI. And again, here's a picture of our PET scanner. This is our technologist and the anesthesiologist, and here's a real baby, and they start in this position. The baby undergoes general anesthesia, is intubated with a tube to control the breathing, and this is actually on the website. So this is our space. And again, it takes a team to take care of your children, and we are very lucky here to have such wonderful people who are dedicated to the mission of the hyperinsulinism program. And special thanks to Susan Becker, the face of the PET program. If you have any questions, I'm available.
Any questions?
We have about 3 minutes for questions.
Hi, you were saying about the F-DOPA not being FDA approved yet here in the United States. Do you know there's anything that we could do, or there's something to get that, move further along so we could catch up with the rest of the world?
Well, I think what Paul said is getting the word out there and being visible, right? Because what is happening is some people who can be instrumental in helping us get this approved have started to encounter personal experiences with family members or friends or distant friends that have babies with hyperinsulinism. And for them, it's a very moving thing. I mean, meeting all of you guys is a very, very moving thing. So getting out there, becoming visible, and really getting involved in this group, I think can help. I think that can really, really be of great help. So I would say getting involved and being out there and being in your communities and really getting people in your community to know about this.
I was going to say, just come and talk to us. There's a lot that can be done, and we need people involved at all levels.
We need voices.
Yes, I'm John Kinsella from Zaraz Pharmaceuticals, and we're in the business of drug development, obviously. But what you'll need to do is target one of the big radioisotope suppliers and get them to commit to developing being supplier, regular supplier of F-DOPA and being able to deliver it on time when you need it. And they're going to have to make a commitment. One of them is going to have to make a commitment to doing that.
Well, yeah, it's a big financial output, and hospitals are not necessarily the place to the person or the institution to do this. That's what we're a little bit stuck here because it's a rare disease. And there are some other uses for F-DOPA, but they're all rare disease uses. So to get a pharmaceutical company to put the investment in and the money to make it is tough. And if you have any suggestions, we've been trying to figure out how to do this.
Well, one of the things I could do is, because we sometimes buy radioisotopes, I could help you figure out who to target.
Okay.
Or who to contact.
Yes.
Because it's kind of like the same kind of business model as somebody developing a drug specifically for congenital hyperinsulinism. They're going to have to price it right. So they're going to have to work a deal with payers to get a price that makes it worth their while, fair, right? To supply that to CHOP in Children's Hospital, Cook Children's and such. So,
Yeah.
anyway,
Okay.
developer's view.
I will come over and get your card in a
John
second.
Kinsella.
So thank you so much, Lisa. That was a great talk. And I just want to emphasize for 1 second the importance of that slide, because we really want F-DOPA to be available, but it's really the team. It's having the expertise to use the PET scan in the right way, to have the surgeon artist and the surgeon who has, surgeons who have so much experience and know what they're looking for. And so CHOP has that team, Cook has that team, and Gosh has that team. And so it's really important to go to a place that has that whole team and can interpret the PET scan in the right way and use it as a tool.